Hello, I'm Doug Muzzio. This is CityTalk. They are Fred and Martha Cooper, Mr. Tosca, Mr. Mukaj, Mr. Atkins, Mr. Principo, Patricia and Philip Reilly. It is a disaster, fragmented, depersonalized, and business-driven. A brave new post-Hippocratic world where medicine's venerable first principle has become an empty shibboleth, where caring is hard to find. He's been called remarkable, one of the nation's most respected leaders of academic medicine, an expert storyteller, and a unique voice in American medicine. He is Dr. Brendan Reilly. Brendan is Executive Vice Chair of Medicine at New York Presbyterian Hospital and the Gladys and Roland Harriman Professor of Medicine at Weill Cornell Medical College. He served as Chair of Medicine at Chicago's Cook County Hospital when that hospital was the inspiration and setting for the iconic television series ER. Before that, he was a small-town doctor in rural New Hampshire, and before that, he was my college roommate. They are among the patients in his remarkable memoir, One Doctor, Close Calls, Cold Cases, and the Mysteries of Medicine. It is the American healthcare non-system. Welcome, Brendan.
Thanks, great to be here.
Long time.
Yes.
Great reviews, great book. I think it's an important book, a book that really lays out in very human terms what medicine is, but more than that is a really damning indictment of the current state of American medicine. So personally, I thank you.
Well, can I say something about that?
Sure.
Because it's not intended to be a damning indictment.
Well, I read it as such. I'm sorry.
Well, the tricky part about medicine is, and this I think resonates throughout the book, is that there's lots of good and there's lots of bad.
Right.
And one of the amazing things about medicine that I've seen just during my own professional lifetime is what medicine can do today compared to what it could do 30 or 40 years ago is unbelievably fantastic.
But
Before you get to the but, it means that an awful lot of people have done tremendous work to advance the science of medicine and then to bring that to patients. The but is that even though the science has advanced tremendously and has the potential to help lots more people, how we actually provide the care, how we deliver it, and I think most importantly, the personal relationship between the doctors and the patients are what are getting short shrift today. And this book is a lot about what it is like to be a doctor, both from a patient's point of view, but I think almost uniquely compared to other books, this is a book about what it's like to be a doctor from the doctor's point of view.
And that gets to the title of the book, One Doctor, and it really has two meanings. One is that the one doctor is you, and that you provide a first-person memoir of a variety of cases that in some ways are as dramatic as anything on ER or Grey's Anatomy, and could be a television series in itself. But the one doctor means something else as well. What does that other one doctor mean?
It gets to this personal relationship business. My opinion is that every person in the United States should have at least one doctor who really knows them well. This is probably less important when you're young and healthy, but believe me, it gets real important as we get a little bit older or begin to encounter our own healthcare troubles, because there's just no substitute for having a doctor who knows you well, and equally important, a doctor who feels like he or she is a partner with you. There's all kinds of tricky decisions that patients have to make, especially as they get older and, as will happen to all of us, eventually get sick. And there's this idea out there that medicine is all science. If you have X diagnosis, you do A. If you have Y diagnosis, you do B. The fact is that there's lots of judgments that have to be made, And those judgments cannot be made by the doctor alone. They have to be made together with the patient. And unless there's some kind of relationship between those two people, especially over a long period of time, often the wrong decisions are made. And so one doctor is all about how everybody needs to have one doctor.
Okay, you open the book with a quote from Sir William Osler from 1904, and let me just read the quote. "Live a simple and temperate life that you may give all your powers to your profession. Medicine is a jealous mistress. She will be satisfied with no less." This mistress has taken you many places. I mean, urban, rural, public, private, big, small, affluent, poor, and Ivy League and slums. Still your muse?
Oh, sure. You know, I'm sure you've thought and heard this many times yourself. People whose job, whose work, is something that they passionately love are very lucky people.
Yep.
I am a very lucky people.
Me too.
And I have been for a long time. And so that is still true today. In fact, the working title of this book, before the publishers, who are a lot smarter than I am about this, picked one doctor, the working title was The Dinosaur's Mistress.
Oh!
The dinosaur, me, and mistress, this medicine that I've been having this affair with for 40 years.
And are continuing having that
Yes,
affair.
I am. Yeah.
You call yourself a dinosaur, and I've heard you compare yourself to NPR's resident car diagnosticians
Yeah.
at Click and Clack at Car Talk.
Yeah.
How are you a dinosaur?
I'm a dinosaur because even in my own professional lifetime, there was a large number of doctors like me whose job was to do what we talked about before, which is to take care of the whole patient. That means that if you're my patient and something is wrong with your eye or your toe or your heart, you come to me first. And most of the time, I can help you. I don't automatically have to send you to the eye guy or the toe guy or the heart guy. I can help you. And out of that comes that relationship I was talking about, which over time then allows me to help you, but it also allows you to know that when I say, you know, what's wrong with your toe, Doug, is not something I can handle. I need to send you to the toe guy. You have every reason to believe that I'm doing it for the right reasons, that I'm not just churning patients so lots more doctors can see more patients and make money. This relationship has a lot to do not just with making patients comfortable, but it actually has to do with the quality of care. So in the old days, there were lots of people like me. Today, there are many, many fewer, and unless important changes happen in the healthcare system, people like me literally will go away. That's why I am a dinosaur. I am literally on the verge of extinction.
What's replacing the dinosaur?
A very fragmented, disconnected system where, for example, and let's be careful here, right? We're making generalizations.
Absolutely.
Medicine is a huge thing, and so there are always exceptions to these generalizations. But more and more primary care doctors are becoming people who kind of do very simple preventive medicine kinds of things, which frankly you don't need a doctor to do. Lots of other healthcare providers can take your blood pressure and give you shots and stuff like that. But more and more primary care doctors are becoming people who refill prescriptions and give you appointments to go see somebody else. That is not what primary care medicine used to be about or should be about. And that is the kind of medicine that I used to do and still to some extent do. And yet, unfortunately, there's a whole younger generation today who look at me cross-eyed when I talk about this stuff because they don't know what I'm talking about.
So not only are you old, but you speak a different language.
Yes, although I tried to redress that a little bit by writing a book.
That's right. Okay. You've described your role and others' roles as sort of a medical maestro. And you're the conductor of a symphony, and you call them the ologists.
Yeah.
What does the symphony doctor do more than what you've already described? Keep going.
Well, so for example, this book actually, most of it is set in the hospital here in New York in present time.
2 weeks in winter of 2010.
That's right. And it describes me, as you said, in first person, taking care of a bunch of very sick, complicated patients at a famous teaching hospital here in New York. And what you see there is that many of these patients, very sick, very complicated, they do require lots of these ologists, for sure, because they're sick, some of them are dying, and even though I'm a good doctor, there's all kinds of stuff that the ologists are better at than I am. The maestro is required, though, because when you're a sick person in the hospital and you've had to see 8 different ologists because you're sick with things that are wrong with your heart and your kidneys and your brain, and maybe you need surgery and maybe you don't, and you need to have fancy tests and all that stuff, there does have to be a person who's overseeing the care for you, who's totally focused on the whole patient. That's not to say that great specialists don't care about people, they do. But their job is to focus on the piece of the person that they are expert at. That's why people like me ask the ologists to see the patients. But someone has to then put it together. Someone has to make sure that from the patient's point of view, the care that is being suggested and provided by all these different ologists comes together and makes sense and results in a good outcome.
So not only do we read about and really enter the lives of some of the people that I mentioned up top, Mr. Tosca, Mr. Mukaj, Mr. Atkins, and Fred and Martha Cooper, during this same period, you had a personal medical emergency or 2 sets of emergencies. Can you describe that as well?
Sure. I think it's actually the reason I decided to write the book. The book is written in 3 parts. The first part is that long Saturday that we talked about before. The middle part is a flashback to a long time ago that we haven't talked about. But the third part is back in the hospital in New York, taking care of these 6 folks in the hospital. What's different about the third part is during that very same few days when I'm taking care of these sick folks in the hospital, I'm also having to deal with life-threatening emergencies of both of my parents, both at the same time. Both of
whom I
whom,
met 45 years ago. Go ahead.
That's right. Both of whom are in their 90s. My father has metastatic bladder cancer. My mother has had cognitive decline with dementia and is also having trouble with her heart. And what was remarkable about that time was that I had a patient in the hospital during those very same days. This is the Mr. Mukaj you're talking about, who had metastatic bladder cancer involving his hip. That's exactly what was wrong with my father. Mr. Mukaj, the patient in the hospital, had opted to do everything. Surgery, radiation therapy, chemotherapy, even though he knew it was not going to cure him, his decision was that was the way he wanted to go. My father, on the other hand, who was cognitively intact and a retired physician, so a knowledgeable person, had decided not to do any of that. And so during those few days, every time I would see my patient in the hospital, I would wonder if we're doing the right thing for him, and I would think about my father, and every time I would see my father, I would wonder exactly the same things about him. So it put me in a position where I was not only just the doctor and seeing the doctor side of the doctor-patient relationship, I was also, in a sense, the patient too, because I was trying to help my father and my mother as best I could. And so I was actually on both sides of this doctor-patient equation. And that was very interesting experience for me. And in looking back after the events described in the book, I said, you know, that might be an interesting thing to write about.
Sort of a digression away from the book a little bit, but those 2 cases, your dad and Mr. Mukaj, really, and several of the incidents and stories that you write about deal with the end of life and how modern medicine treats end of life and how folks treat end of life. And that, talk about that from both sort of a doctor's perspective and sort of the son's perspective.
One of the great things that's happened recently in American medicine is that palliative care specialists have gained some ascendance in the healthcare system, and palliative care folks are people whose job is to try to help make patients feel better. They're not necessarily people who can cure their diseases. Their job is to make people feel better, which in the old days is what doctoring always was about. That's the whole idea. there's a quote from Atul Gawande, for example, that says something to the effect of, you know, medicine's ultimate job is to fight death. But, you know, in the long run, death's going to win.
Yep.
And so there is some wisdom required in figuring out how hard and how long do you fight, and when do you say, you know, I think my time has come, and what's most important now is how I feel. And am I able to reduce my suffering? Am I able to interact with my friends and my family during whatever time I have left? Many Americans haven't thought about this stuff. We tend to think about it when we have to, you know. I mean, really, who wants to think about this stuff if you don't have to?
Right.
But unfortunately, lots of times when you get really sick, you don't have much warning about it. You're suddenly thrust into a situation in a hospital where you're having to make these life and death decisions, and you haven't really thought carefully about what you personally want when your time comes. And so, for example, in the case of the Mr. Mukaj we're talking about, he's saying, I know I'm going to die of bladder cancer, but I'm choosing all of these options to try to help prolong my life as much as I can. My father, on the other hand, knew exactly the same things and made the decision, no, what's more important to me is the quality of my life. I don't want to go through the harms that are going to accrue to me by having operations and radiation therapy and chemotherapy. Medicine is always this balance between harm and good. And for every patient, it's a different kind of decision, which is, again, why more and more it's so unfortunate that many patients are very alone in this process, which is why this business about a relationship with the doctor is so important. If there is a doctor you know, whom you trust, and you can bounce ideas off, you're more likely to make smarter decisions, not medically or not in the doctor's opinion, but what's smart for you and your family and your loved ones.
Advice to folks, particularly those of us who are in the Medicare ages, in terms of what they might do to make this transition easier. Also, legally, what might they do as well?
So as you know, there are instruments available to folks to clarify what they would want were they to become ill in certain ways. They are called advance directives. Many people think of them as living wills. Living wills in general don't accomplish this goal. Living wills tend to say things like, if I'm in a desperate situation, I don't want to have heroic care. Well, what's that?
Right.
Right?
And what's desperate? Right.
Exactly. And so what's more important is that preferably together with a person you know well, a family member, a friend, whoever, you and that other person meet not once, but many times with, again, your doctor, if you're lucky enough to have one doctor, which most people don't anymore, but if you are, and begin a conversation about what I may or may not want under certain conditions. Folks in our age group, well, are lucky in a sense, because we're at least having to begin to think about this, and many of us have had to confront these situations with either our parents, other loved ones, and so there's a little context there that allows you to think more clearly about this. Legally, crazily enough, every state is completely different.
I know.
In how it allows people to do this. But that said, you have to look at the bright side. Compared to 20 years ago, things are better than they used to be. People are beginning to pay more attention to this. Most Americans still haven't executed any kind of advance directive, but many more have than used to. Unfortunately, and it's the last thing I'd say about this, is just having this piece of paper, you know, with a notary public saying something about it, really doesn't do you any good unless you also have this doctor who's going to help you implement your will. Because if you're unlucky enough to wind up in an emergency room deathly ill, and your doctor is nowhere to be found, well, the way American medicine works is that they do everything they can do to save your life, which is fine. But if you're 100 years old and have metastatic cancer, that may not necessarily be what you want. And so a lot of this has to do with communicating what you want and trying to make sure that it actually happens.
Okay. So the first section of the book and the third section of the book are, in a sense, medicine as it is now.
Yeah, in the hospital.
In the hospital. But the middle the flashback to rural New Hampshire 25 years earlier, where you're a primary care physician, you're in a small town, sort of medicine as it used to be, sort of the medicine of house calls. And then we come to your cold case,
Yep.
the case that's sort of still in you and almost will never leave. It's one of those viruses that you can't expunge, and you wouldn't want to.
Right.
Exactly. Talk about that time and that cold case and what it meant to you.
So at the time, I was a primary care doctor in a small town, but the small town was a small New England college town. I worked at Dartmouth Medical School, and part of my job was to be the small town doctor. And by far, the best medical experiences of my life involved making house calls, going to folks' homes, where doctors learn so much more about their patients than just seeing them once in a while in the office. But the cold case was actually the case of an elderly couple, people I knew well, and actually people I loved. They were wonderful, wonderful people. And to make a long story short, both of them got very sick, and one of them I was able to help a lot, and one of them I wasn't able to help. And his outcome was tragic. Part of it was my fault. Part of it was the system's fault. And memories of that case have never left me because it actually made me who I am in some ways. The lessons that I learned there, I've kept with me. And those lessons have informed what I've tried to do in the years that followed. And one of the cool things about that cold case was that that patient himself had his own cold case. And his own cold case was Amelia Earhart, because this patient was a famous engineer who had actually designed the navigation system for Amelia Earhart's airplane on her trip to travel around the world, ultimately her fatal trip to travel around the world. And he had been guilty for years because his navigation system, which was far better than the old ones, had been removed from her airplane just before she took off for all the wrong reasons. Again, a series of complicated errors that he felt responsible for, which in many ways is exactly what happened to me with him. I felt responsible for some of the errors that wound up taking his life. And so there's this very unusual mirror image between my cold case and his own cold case. And as you know, they're still looking for Amelia Earhart. And so Fred, the name of the patient, if he were alive today, would still be frustrated because his cold case hasn't been solved. But in many ways, my cold case was solved. I think I did eventually find out why Fred died and what my role in it was.
And read the book.
And I learned a lot from it.
Okay, let's go to the modern medicine, or what you call the non-system of healthcare in the United States. What are the perversities, the problems with current modern American medicine?
Boy, how much time you got?
Maybe we could do another show.
Yeah.
And in fact, I'm serious.
Okay,
go ahead.
But again, let me be clear about this. I'm not the Che Guevara of American medicine.
We understand.
I am establishment medicine, and there's an awful lot that's great about American medicine. But the perversities, you know, maybe even better than I know. They occur at the economic, political, and social levels, as well as the medical level. The biggest underlying problem is that it isn't really a system at all. It's a disconnected series of interests, each of which has its own set of incentives, whether you're talking about insurance companies, drug companies, hospitals, doctors groups, individual doctors, nursing homes. And these are pieced together in almost serendipitous ways which vary in different parts of the country. And in no sense is it a healthcare system like many advanced Western countries have. And that, whatever people's politics are, that is why the Affordable Care Act is so important. I think even President Obama would say it's not going to solve all the problems, but it is the beginning of a change to at least begin to create a system. And the main change is to try to get all Americans into health care.
That seems to be the sine qua non.
Most Americans don't get it when they hear that the United States on many measures, ranks dead last among industrialized nations in various healthcare metrics. And yet at the same time, for example, in a city like this, you walk down the street and you see these magnificent Taj Mahals of medicine where it is true. You can get the best care anywhere, and miracles, quote unquote, are actually happening in these places every day. How can that be true, and at the same time the United States ranks last? Well, if you're the President of the United States, your answer to that is, well, it's always going to rank last until we get everybody into the system. Because the folks who are out of the system are most of the people who are suffering terrible outcomes. And they're suffering bad outcomes because they can't get the medical care that they need. And so his first priority has been to bring the disenfranchised and the underserved Americans into some form of health care, to begin to address this problem of how the nation as a whole, all of them, need to do better than we're doing now.
In your intro, you talk about the book you want, as Hamlet did, catch the conscience of the king. Who's the king in this situation?
Yeah, that's a good question. You know, I mean, I'm old enough to remember when people asked questions like that, and the answer would be, well, I want the public, I want readers to know more about what's going on. And well, okay, and then what do? Well, in the old days, the answer to that was, you call your congressman. That's what they got elected to help fix, right? Well, today, I'm not so sure that's going to do it. So who the king is today, I'm not sure. What I hope happens is that real people read the book, realize that there are challenges out there, realize that what's happening today is not necessarily what's best for them. And then what happens after that, I'm not sure. I just hope more people begin talking about this fragmented, disconnected thing we've got going here. And while the current thing, the system, can be very good for lots of the vested interests in the system, in general, it is not very good for patients. How we get from here to there, I'm not sure.
And I don't think anybody else is either. But thank you, Brendan. This is an important book. It's really odd here interviewing you 45 years later, I must say. But my thanks to my friend, Dr. Brendan Reilly, for being on the show, for sharing his experiences and analyses of modern medicine, and for his extraordinary memoir, One Doctor, Close Calls, Cold Cases, and the Mysteries of Modern Medicine. See you next week here on CUNY TV. Hello, I'm Doug Muzzio. Let us know what you think about this show. You can reach us at CUNY.TV. When you get there, click on the bar that says Contact Us and send your email. Whatever it is. Thanks, no thanks, obnoxious, do it. Send it.